Hello, CAC2 colleagues. This is Joanne Salcido from CAC2 member organization, the Pediatric Brain Tumor Foundation. Thank you, everyone, for joining us for today's webinar. I like to start out with a special call out to Amy Weinstein, for helping organize this webinar, and Scott Gilman for driving our webinar technology. Thank you very much. Fall is a busy time of year in general, but of course September in particular stands out in a very special way. So if you hadn't had time to appreciate how much was happening in September for and by our community for Childhood Cancer Awareness Month, I want to please start out by encouraging you to check out the event map that's available at cac2.org/events. Or if you go back to Vicky's October monthly email announcement, you'll see a link directly to that event map. So please check it out. We'll go on to the next slide, and you can see that I have just one reminder before I go into some housekeeping, which is to say, hip, hip, hooray for the first 5 years of CAC2, if people can believe it, and to make sure that our next 5 years are as positive and as productive as our first 5 years, the CAC2 board has instructed or is meaning to reach out to all of our members and solicit feedback. So when you receive an invitation to provide your input, please participate. That's the single and very important announcement I want to make. Now going on to the usual webinar housekeeping basic instructions. Your microphones right now are muted as a courtesy to everyone. Questions will be deferred to the end of the session. You can pose a question, and this is what we'd ideally prefer, by typing it in your webinar dashboard. That will facilitate question and answering, and we'll be able to get through more. If, in an unusual circumstance, you believe you need to provide more context than you can possibly type in, although not too long, we may be able to allow you to voice that. We'll have to kind of make that call in real time, depending on how the flow is. So ideally, please type it in. If technology is a problem, please send an email to webinar@cac2.org. And please know that we're recording the webinar today. We'll then process it, post it to the CAC2 webinar website as soon as possible for viewing at your convenience. And finally, if we go on to the next slide, as you know, it's important that we recenter ourselves and remind ourselves of the CAC2 values that we share as a coalition. At the top of the list, we put the children and their families first in absolutely everything we do. We are supportive of each other's efforts and very mindful to not duplicate efforts or compete. We'd like to take ownership of the commitments we make to each other, and we are good stewards of our resources. In our aim to give voice to the childhood cancer community in a coordinated way, we stay and are action-oriented. So now, moving on to the point of us gathering today on the webinar, it's my pleasure to introduce our speaker, Dr. Tara Brinkman. She's a licensed psychologist and assistant member in two departments, the Department of Epidemiology and Cancer Control and the Department of Psychology at St. Jude Children's Research Hospital. Prior to joining the faculty there, she completed her clinical fellowship training at the Dana-Farber Cancer Institute. Dr. Brinkman has a special interest in studying neurocognitive, social, and emotional outcomes for survivors of CNS tumors. She's currently conducting studies to examine brain integrity and social cognition in survivors of medulloblastoma, functional independence in adult survivors of pediatric brain tumors, and the psychosocial consequences of these neurologic morbidities in long-term survivors. The title of her talk today, as you see on the screen, is Functional and Social Independence in Adult Survivors of Pediatric Brain Tumors. Welcome, Dr. Brinkman. Please take it away.
Thank you so much. I want to thank you all for the invitation and the opportunity to talk with you today. And I'm excited to share some of our research on independence and adult survivors of pediatric brain tumors. So the reason we're able to talk about long-term adult outcomes today is because we've seen dramatic improvements in childhood cancer survival rates. And so you'll see, as with the statistics shown on the right there, that today over 83% of children with a malignancy will achieve 5-year survival. It was estimated that there were 420,000 survivors in the U.S. in 2013. By 2020, it's estimated that there'll be 500,000 childhood cancer survivors, and this translates into 1 in 750 individuals in the United States being a childhood cancer survivor. So the figure on the left, what that really highlights nicely is the percentage of children surviving childhood cancer. Across the bottom, you can see years from diagnosis and 5-year intervals. And what's really striking by these different lines reflecting different periods of diagnosis is that early in the 1970s, we saw a much lower 5, 10, 15-year survival than what we're seeing in children who are diagnosed in the 80s, 90s, and now 2000s. Again, this just reiterates the drastic improvement that we've seen in survival from the 1970s to the early 2000s. And the population we'll be talking about today is CNS tumor survivors. And here you can see that in the 1970s, fewer than 60% of children diagnosed with a CNS tumor were surviving, and that's well over 70% today. And specifically in brain and CNS tumor survivors, a child diagnosed today, is 74% of them are expected to achieve 5-year survival. So these are fantastic gains that we've seen in survivorship. But we know that survivorship does not come without costs. And CNS tumor survivors, as are many other childhood cancer survivors, are at risk for developing chronic health conditions. And really, there's an adage that rings true for survivors of CNS tumors, and that's that survivorship often comes at a cost. And it's really trying to understand that cost that's important. And when we think about some of these late effects or the long-term complications of having a brain tumor and receiving treatment for a brain tumor in childhood, we know that survivors are at risk for second and even third cancers. We know that they're at risk for multiple endocrinopathies. So these are things like hormone deficiencies, obesity. There's cardiovascular risk, including increased risk of stroke. Survivors of brain tumors are at risk for neurocognitive impairment, including thinking or changes in thinking, learning, declines in intellectual capacity over time. We see these survivors struggle with neurologic problems, so seizures, muscle weakness, and also neurosensory deficits, so problems with hearing, cataracts, vision loss. So what we're really, I think, challenged to do is think about what is the ultimate outcome for these survivors. So we know we're seeing dramatic increases in survival rates. We know that as a result of the treatments that are required to achieve these survival rates, survivors are at risk for a number of late complications. But nevertheless, we still want these survivors to attain independence throughout the course of survivorship and adolescence and adulthood. And what we really strongly think is that attaining independence is a primary and a really central goal of adult survivors of pediatric brain tumors. So when I'm talking about independence, what am I talking about? So this is really the ability to do things on your own without relying on others. And often this is developmentally determined. So when we think about young kids becoming independent, we think about them starting to eat themselves or feed themselves, dress themselves, bathe themselves. In adolescence, we see teenagers start to really increase their independence from their parents in terms of establishing social relationships, starting to engage in extracurricular activities independently, driving, they're graduating from high school. For young adults, we want these adults to be attending college, gaining employment, starting to live on their own, developing romantic relationships, managing their finances, attending medical appointments for our survivors, and being able to plan for the future. What we know in terms of past studies with respect to independence of survivors of CNS tumors is that our survivors, our long-term survivors, have a really hard time achieving some of these things. But past studies have often looked at these in isolation. So for example, there's reports saying that survivors have a hard time living on their own, or survivors have a difficult time achieving or gaining employment. And what we know in the context of everyday life, that these things don't happen by themselves. So you are living independently or not, you're working or not, you're driving or not, all of these things are happening together. So what we really wanted to do was to try to build on our knowledge base and see how these things occur together. And so that was the aim of our study, was to really look at functional and social independence in long-term adult survivors of childhood brain tumors, and to look at different patterns of independence, see how prevalent or frequent those patterns were, and to look at predictors of independence while at the same time considering multiple markers of independence at the same time. So to do this, we leveraged the St. Jude Lifetime Cohort Study. So this is a study at St. Jude Children's Research Hospital, and this is a cohort of survivors of childhood cancer who we've identified sort of retrospectively looking back, but who we follow prospectively with longitudinal medical follow-up. And these survivors come to campus for 2 to 3 days at a time. They undergo extensive medical evaluations, physical performance evaluations, neurocognitive testing, so a complete battery of research evaluations to really help us understand the long-term health outcomes of childhood cancer. And to be eligible for this cohort, right now I think we have over 4,000 survivors who are eligible. They had to be diagnosed and treated for cancer at St. Jude and at least 5 years from diagnosis. So for our study, we restricted our population a little bit. So we focused on CNS tumors specifically. And because we wanted these survivors to be at an age where they should be doing things more independently, they were at least 18 years of age at the time of the study and 10 years from their diagnosis. And we excluded survivors who had pre-existing conditions, such as a brain injury or a stroke before their diagnosis, because we wanted to make sure the outcomes we were looking at were related to the actual brain tumor diagnosis and brain tumor treatment. So we ended up with 306 adult survivors who were enrolled in our study. And this shows you the distribution of study participants. So the majority of survivors were diagnosed with astrocytoma, about a quarter were diagnosed with medulloblastoma, and 12% with ependymoma, and this will be familiar to you all as these are the most common types of childhood brain tumors. And in terms of our study participants, just very briefly, they were about 25 years old at the age of study, but that range was from 19 all the way up to 53 years of age. So we did capture a good chunk of young, middle, and middle-aged adulthood. Survivors were on average 9 years of age when they were diagnosed, and they were anywhere from 11 to 42 years from their initial diagnosis and treatment. So the majority of survivors in our study were male, non-Hispanic, white. And then I just wanted to highlight here for you, the majority of survivors in our study were diagnosed in the 1990s, with a smaller proportion diagnosed in the 80s and 2000s. In terms of how these survivors were treated, about a third did not receive surgical resection, and about half had gross total resection of their primary tumor. 60% did not receive any chemotherapy, and there's a fairly even distribution in terms of treatment with radiation. So about a third received none, a third received focal radiation directly to the tumor, and a third received cranial spinal radiation, which involved the whole brain and the spinal cord. And you see below that the max radiation dose to the different regions of the brain. And essentially the takeaway from that is that these survivors got fairly high doses of cranial radiation therapy, higher than what's often used today. So our primary outcomes, as I mentioned earlier, were functional and social independence. And we measured that, as I had mentioned, using 6 different markers of independence. And so our first marker was independent living. So are these survivors living on their own, or are they still living in a situation where they're requiring support from a caregiver, whether that be a parent, an older sibling, or an assisted living facility? We also looked at employment. So are survivors working full-time, part-time, or are they unemployed? We looked at marital status, and this also included long-term partnership in addition to marriage. So were survivors single? Had they never been in a long-term partnership? Or do they have a history of marriage and being with a partner? We looked at whether or not survivors required assistance with routine needs, and routine needs were defined as things such as assistance with everyday chores, doing necessary business, going shopping, needing assistance, sort of just getting around the community. We looked at assistance with personal care needs, and this is a higher level of care that's required. So this is assistance, eating, bathing, dressing oneself. And then we also looked at whether or not survivors had a driver's license. So again, the goal and the way that we handled all of this statistically was to see how these different markers, how they co-occurred with one another in our survivor population. And what we were interested in was how physical performance deficits might be associated with these functional and social independent outcomes. So we had published some data previously showing that survivors of childhood brain tumors have a really difficult time navigating their physical environment. So common barriers such as a curb or a heavy door or a slick sidewalk, all of those things made it harder for survivors to access their environment because of some physical performance deficits that they had. And what we were thinking was, well, if they have a hard time actually physically accessing their environment, that's probably going to contribute to how independent they're able to be as adults. So we wanted to see how these different aspects of physical ability also played into independence. So we looked at aerobic capacity, which is really exercise tolerance, strength, flexibility, balance, mobility, and then activities of daily living, which is really adaptive physical function. So tasks that you need to do every day to get by that have a physical component built into them, such as writing a sentence, standing up and turning around, putting on a jacket. So these were our primary factors that we were interested in seeing how they predict level of independence. So in terms of our outcomes, so this was the main outcome of our study, and this is what we were most interested in. What level of independence are we seeing in these survivors? And we really identified 3 different groups of survivors. Now, this first group, we called them independent survivors, and this is about 40% of the survivors in our study. And this is what we want to see for any adult, any survivor of childhood cancer. So these individuals are married or they have a partner, they're living independently, they're employed full-time, they don't require any assistance with routine or personal care needs, and they're driving. So this is essentially sort of our gold standard in terms of independent outcomes. We identified a second class who we called moderately independent. So they were doing a lot of the things that the independent survivors were doing, but there were a few differences. So they weren't married, they didn't have partners, they were still living dependently for the most part. So they still required assistance from their parents or another caregiver. They were working part-time in addition to full-time, but they still didn't require daily assistance, and they were able to drive. And then we identified a third group, and this is the group we called our non-independent survivors. And again, this was about 1/3 of survivors, and this is the class that really was most concerning to us. So these are the survivors who have the outcomes that really reflect that they probably have a lot of morbidity from their disease and treatment. So these survivors weren't married, they're still living dependently, they weren't working. A lot of them required assistance with routine and personal care needs, and they weren't driving. So this figure here just sort of depicts visually what I'm talking about. And I'll walk you through a couple of columns because I know it's confusing. So if you look at that first row of independent living, or I'm sorry, the first column of independent living, and you have the 3 rows, our independent survivors, our moderately independent, and our non-independent. So what we see in those pie charts there is we want that to be blue. So blue means they're living independently. So you see in class 1, 99% of survivors in that class were living independently. When you drop to class 2, only 6% were living independently, and in class 3, our non-independent class, only 3% were living independently. And then if we transition a couple of rows to or columns to the right, if you look at, for example, assistance with routine needs. So in our independent class, about 11% still needed assistance with routine needs, 4% in our moderately independent class. But then in our non-independent class, about 78% of the survivors needed assistance with routine care needs. And we see similar patterns with driver's license, which is the next column over. So 87% of independent survivors were driving, 92% of moderately independent survivors were driving, whereas only 5% of our non-independent survivors were driving. So I think this figure nicely depicts sort of the differences we're seeing in individual aspects of independence across the different classes, but again, recognizing that each of these groups is comprised of all of those aspects of independence. And just to reiterate what I said earlier, we wanted to consider how all of these things co-occur in everyday life. So as I mentioned earlier, one of the things we wanted to know after we identified these classes is, well, what were risk factors for survivors being non-independent? And so here what you see are the different disease and treatment exposures, and then the different classes. So we see the moderately independent compared to the independent, and the non-independent compared to the independent. And so for this first line, what you see is we looked at treatment with cranial radiation therapy. And what this tells us is that survivors who were treated with cranial radiation therapy as a child, specifically cranial spinal radiation therapy, were 4.2 times more likely to be non-independent than independent. So this tells us that treatment with craniospinal radiation is a huge risk factor for survivors not being independent as adults. We didn't see anything pop out in terms of surgical resection being a risk factor for independence. We did see that survivors who had a history of hydrocephalus with shunt placement were at significant risk for being non-independent. And we also saw that survivors who were younger at the time of diagnosis were at risk for being non-independent as adults. And what's probably not surprising that most of you are probably aware of is that these are also risk factors for cognitive impairment. And when we talk about cognitive functioning, we're thinking about skills that are necessary for thinking, learning, so being able to pay attention, sustain attention, to remember things in the short and long term, to plan, problem solve, think ahead. So we looked at cognitive functioning as well to see how it was related to independence. And what you can see in this figure is along the vertical axis, that's the percentage of survivors who were impaired across the different domains. So attention, again, being able to pay attention in the short term and then maintaining attention over a longer interval of time, memory, working memory, being able to hold things in your mind and reproduce it, long-term memory, and executive functioning, which really refers to planning, problem solving. And so what you can see really clearly here is the yellow bar reflects independent survivors, the gray bars, moderately independent survivors, and the red bar, non-independent survivors. So I think it's very striking that across all domains of cognitive functioning, we saw that survivors who were non-independent were significantly more impaired, or they had a greater proportion of them were impaired in those areas. What was interesting, though, is cognitive impairment was associated with risk of non-independence, but not of moderate independence. And this is a group I'm going to keep coming back to, this moderately independent group, because we think this is a group that might be especially amenable to intervention. So this is the group, again, who had some of those factors of full independence, didn't quite achieve all of them, whereas the non-independent group really didn't have many of those factors of independence at all. So this is, these are some models where we look specifically at those physical performance deficits I had talked about before. We know brain tumor survivors are at risk for a lot of physical health impairments, and this is accounting for their cognitive impairment. So after we take into account that cognition affects level of independence, we wanted to look at how does physical performance ability also play into that. And so what we see here is that survivors who had impaired aerobic capacity, and again, this is reduced exercise tolerance, that those survivors were almost 6 times more likely to be non-independent than independent. We saw that strength was a significant predictor, and this was one of the few variables that was significant for the moderately independent group, which was important because we were really looking for markers for this group. Flexibility, so survivors who had impaired flexibility were almost 4 times more likely to be non-independent than independent. Balance didn't seem to be super important in our cohort, but adaptive physical function was really important. And again, these were the physical activities that are really required for day-to-day, just daily living, day-to-day activities. So we also wanted to know if these survivors are non-independent, does it matter to them? And these data suggest that it does. So what we see here is if you look along the vertical axis where you see the mean score, so this is a measure that survivors completed just reporting on their overall quality or satisfaction with their life. And what we would expect is an average score of 50, where that solid red bar is. And you can see across all the groups, they're slightly below that red line. But again, this non-independent group, the group denoted by the red bars, and these aspects of physical function, the ability to do daily activities because of physical impairments, their general health, their satisfaction with their social function, all of those were reduced in survivors who were non-independent. So I think this was really striking for us because not only did we identify a group of survivors who are non-independent, but we see that it matters in terms of their perception of their quality of life. So I just want to highlight real quickly, without all the numbers and tables, what the main predictors were that we found of independence versus non-independence. And again, try to focus a little bit on that moderately independent group. So again, we had the three groups. We had independent survivors, moderately independent survivors, and non-independent survivors. So when we compared the two extremes, the non-independent versus the independent, what we found is that cranial spinal radiation, hydrocephalus with shunt placement, and younger age at diagnosis all predicted non-independence. In terms of clinical factors, we found that cognition or general intellectual impairment and physical factors such as impaired aerobic capacity, strength, and adaptive physical function all predicted non-independence. So I think this is really important for us to know because these are potential targets for intervention for this group. And what it tells us for the non-independent group is that we're likely going to have a multimodal approach to intervention. So we're going to have to think about how do we manage cognitive late effects, physical late effects together and not just focus on one or the other. For moderate independence, when we first compared them to the completely independent group, we didn't see any specific disease or treatment factors. So there's nothing in terms of their brain tumor diagnosis, the amount of radiation they got, hydrocephalus, none of those factors I distinguished between those two groups. But we did see that the moderately independent group had impaired strength and impaired adaptive physical function. So what this suggests to us and what we're going to look at moving forward is that perhaps a physical performance-based and exercise, a strength training intervention might be useful for these survivors to help them overcome physical obstacles or barriers in their environment to achieve greater independence. And what I hadn't presented to you yet, and this was a comparison that we thought was really interesting, was, well, what's the difference between the group who's moderately independent and the group who's not independent? And you see a lot of the same factors as when we compare the non-independent to the fully independent, which again suggests to us that this moderately independent group is much closer to being fully independent than non-independent. So the moderately independent survivors were less likely to receive any kind of cranial radiation therapy. They were older when they were diagnosed, and they were younger at the time we studied them in St. Jude Life. And what this also might mean is that these survivors are still in their early 20s, in their early 30s, so they're still maturing and gaining this normal level of independence as any developmentally typical adult would. In terms of clinical factors, again, moderately independent survivors did not have the pronounced cognitive impairment that we saw in the non-independent survivors, and they were less likely to have impaired aerobic capacity and adaptive physical function, though they still had deficits in these areas. And what I wanted to highlight next, though, is I spent the beginning very briefly talking about how we've seen these tremendous gains in survivorship, though it has come at some cost with respect to long-term health morbidities. But I think we're seeing evidence for progress in these outcomes, too. So this is from the cohort I just presented to you, and this is decade of diagnosis for our survivors and how that fell out, whether they were independent, moderately independent, or non-independent. And our numbers are small, so again, this is just preliminary data, but what I wanted to highlight here is that you can see for non-independent survivors that the proportion of survivors who are non-independent is really decreasing dramatically as decade of diagnosis is becoming more contemporary. So the more contemporarily treated survivors, which often means less radiation, conformal radiation, so more advanced technology with respect to radiation delivery and more precision with surgery and advanced imaging, we are seeing fewer survivors become non-independent as adults. And then to sort of validate this, we also had a group of CNS tumor survivors in the childhood cancer survivors study, and we looked at the same thing, the same classes by decade of diagnosis. And again, you see a very similar trend. The decades are slightly different just because of the natures of the cohort, but you can see that with increasing time, we see a much smaller percentage of survivors who are non-independent. So I think this is great news. This really speaks to the fact that we are seeing some potential long-term progress in our outcomes. And this again just shows this visually. So this is from the childhood cancer survivor study, and this actually involves survivors of acute lymphoblastic leukemia and non-Hodgkin's lymphoma as well. So other survivors who got CNS-directed therapies. And what you can see, really, I want to draw your attention to the figure on the far right for the non-independent survivors, is that red dot there indicates the proportion of survivors who are non-independent. And again, by the 3 decades of diagnosis. So we have the 70s, the 80s, and the 90s. And you can really see a clear linear change in the proportion of survivors who are non-independent. Again, great news, and I think this speaks to the fact that we are seeing positive long-term outcomes. So what do we do about this right now is the question, and this is something I'm happy to engage in some discussion about. So from a research and clinical perspective, we're really interested in looking at interventions to promote independence. And so for our older adult survivors, this might be teaching adaptive skills, so adaptive living skills such as cooking, doing laundry, managing finances. I think we identified a group of survivors who have muscle weakness, who have difficulty with flexibility, who have hard time navigating physical barriers in their environment, who might benefit from some prescribed exercise and strength training regimens. We know that cognitive remediation has shown some positive effects in kids who are younger and not quite in adulthood in terms of survivors of childhood brain tumors, and that might be an important component of this of rehabilitation approaches, specifically for the group of non-independent survivors who have both cognitive and physical health morbidities. There's resources such as vocational rehabilitation, often available at the state level, where they can provide on-site job training to help survivors sort of acclimate and learn the basic skills required for successful jobs. There's driving rehabilitation programs that can help tailor either the vehicle or driving strategies based on specific sensory deficits that a survivor might have. In terms of families right now, I think whose kids are undergoing therapy or who are earlier in the survivorship stage, I think modifying and determining goals for independence is key. And so I think the first step to this is really understanding potential physical and cognitive late effects. And that's information that should be available from your treatment team from the very beginning. I know it's not often on the forefront of minds when your child's going through treatment, but it's information that is readily available. And then work with your team to establish appropriate goals. So sometimes we might, because of a physical impairment or cognitive impairment, might have to adapt or modify what a long-term goal or expectation is. But being able to do that, because we really want to set these survivors up for success, and just because we have to adapt or modify an outcome doesn't mean they can't be successful. And I also think modeling and encouraging independent behaviors. We see a lot in clinic that caregivers have taken their children and survivors to medical appointments, throughout childhood, adolescence, young adulthood, but really encouraging at the most basic medical appointment level, having these survivors start to ask the questions, modeling what it's like to be able to go to a healthcare appointment or schedule an appointment, and really encouraging some risk-taking for the survivors to be able to learn these independent behaviors. And I think there's certainly things that to be cognizant of. So we're not going to, really focus on driving rehabilitation for a survivor who has uncontrolled seizures, because that's contraindicated. So really being aware of what the survivor's physical and cognitive limitations are, but working to adapt environmental and behavioral strategies to promote independence. So overall conclusions on independence in terms of what we know right now today, I think the heavy message is that a substantial proportion of pediatric CNS tumor survivors do not achieve complete independence in adulthood. We know that risk factors for non-independence include cranial spinal radiation, cognitive impairment, and physical performance deficits. Non-independence is associated with reduced quality of life, which again, it matters. It matters to these survivors. We really need interventions, and part of this falls back, the onus of this falls back on researchers to start to study and evaluate and disseminate interventions to target these physical performance deficits and adaptive skills. And then upfront therapies should be continued to be tailored with the ultimate outcome in mind. And as I showed, I think we're seeing some evidence for progress with respect to independent outcomes, but to continue to be mindful of, we're at a point where 5, 10, 15-year survival is not enough. We really need to think about the quality of life and the ultimate outcome for these survivors. So I know I ran through that quickly. I'm happy to take questions. I want to acknowledge our funding resources and the survivors and families in our cohort who are just provide invaluable feedback to us, and are always willing to participate in our studies. So thank you for your time, attention, and I am happy to take questions.
This is Joanne. Tara, or Dr. Freak, that was just wonderful, a lot to digest. I want to remind people that you'll be able to spend time on these slides once we post it again, but there's a lot of rich information. Thank you for combining both the numbers to show everything's data-driven and also the qualitative conclusions, so thank you. I'm waiting for some questions to come in, but until they do, I have one of my own that of course you touched on in your very last point, Tara, which is around interventions are important, and you're talking about the ones that will intervene, once treatment is done, what can we do exercise-wise or perhaps even in the course of treatment. But to the point of drug development, you made it very clear that these improvements in survival have come really as a result of better technological improvements in radiation, surgical precision, right? Not so much in the toolkit that we have drug-wise. So to the extent that you might have insight into those trial designs where potentially drugs in the future are where we will increase survival and also, very importantly, reduce morbidity. Do you see those kinds of endpoints being integrated early in the drug development process so that we aren't having to find yet again a whole other set of interventions for drugs that have a lot of morbidity? How would you see?
Yeah, so I'm less familiar with the actual drug development aspect. What I can tell you is what we see, at least in pediatric brain tumor survivors and historically with ALL, that cranial radiation is a major culprit in these adverse outcomes. And on some of the frontline trials that we're doing here at St. Jude, there's absolutely efforts to increase the precision with which it's delivered, the transition from traditional conformal to 3D conformal, from protons to photons. So there's a lot being done. And there's actually, at least at St. Jude, we have a lot of measures embedded on those frontline clinical trials to start to look at these outcomes earlier to see if we're seeing improvement. And we also have trials where we have interventions embedded in the early clinical trials to see if we do cognitive training, if we do physical performance training while these kids are on campus getting therapy, can we potentially offset some of these late outcomes? So there's work being done. I can't speak specifically to the drug development aspect of it, but in terms of modifying radiation, which again has been a major culprit for us, and sort of more proactively or prophylactically intervening before the deficits emerge. Does that make sense?
Yeah, it does. I think, clearly there's a whole lot of effort spent and research investment on improving the molecular treatment kind of approaches and hoping for impacts. And we need to keep, now that we know all this, we should really act like we know all this and insist on
absolutely.
these kinds of outcomes, right?
Yeah, and so
go ahead.
No, go ahead. You're fine. Go ahead.
I was just going to say I don't see anything, but there's something lighting up on my. Vicki, do you have a question?
Yes, Joanne, this is Vicki Binger, and I appreciate the presentation very, very much. And I especially appreciated the opportunity to see the St. Jude cohort survivors that have been followed in comparison with the childhood cancer survivorship cohorts that would include survivors from a variety of other, I assume, children oncology group hospitals. Terry, you may not be able to speak to this in a data-driven way, but would you generally expect that what you observed in this study to generalize to children and teens and adolescents treated regardless of where they were treated, or would you think that you would find differences, particularly in that middle category of partly independent folks, would not just when they were treated, but where they were treated, would you expect that to be in the data more generally, or would that not matter so much because the treatments are quite similar?
Yeah, no, I mean, I think it absolutely would matter. So one of the things we wanted to do was really validate the approach we took with developing these classes, because it was a very statistical method, and we wanted to make sure that it actually played out and made sense in other survivors as well. So we looked at this in our cohort of ALL survivors too, and we actually found 3 classes that were very similar that we called independent, moderately independent, non-independent. The distribution was very different. So a lot of the ALL survivors were more independent or moderately independent. We didn't have that big chunk of non-independent survivors. And the components that went into it differed. So with the ALL survivors, for example, we didn't really see a lot of them requiring assistance with routine or personal care needs. We saw a lot more part-time employment instead of unemployment. So I think we would see similar patterns, but I think you hit on the point that moderately independent class would look very different by the nature of the diagnosis. And I would expect, for example, if we looked in solid tumor survivors, that we might see a bigger contribution of some of these physical performance deficits as well, rather than the cognitive deficits.
Would you be able to, this is Joanne again, following up, dovetailing on Vicky's question, I'm also wanting to pay attention to anyone else's, but right now I think I can pose it. So you can expect a different profile of independence across diagnoses, ALL versus CNS, for example, you just explained.
Right.
What about across centers? And that would be, I'm not sure how one would do that study well. But there's a sense that proton treatment in one place is the same as anywhere. And any kind of treatment that these cohorts would have gotten at St. Jude in that time period would have been similar to treatment at other centers. Whether or not, not maybe the percentage of children at different centers getting certain treatment will vary. But for anyone giving that radiation, CSI, it would have been the same, whether it was at St. Jude or anywhere else, for example.
Yeah, largely. I mean, and that's a question we get a lot about the research we do. St. Jude's a very unique institution. You have an exceptional number of resources to provide these patients. But when we've looked at it, most of our historical treatment protocols have not differed that much from protocols at other institutions. I think one of the things that our survivors may benefit from in terms of independence is we have a really great, as a lot of hospitals do, but we have really great long-term follow-up with respect to social work, psychosocial providers. So in terms of promoting independence, we have a lot of resources built in. But I think you're right. I think in terms of the delivery of the cranial spinal radiation, the chemotherapy doses, methods of delivery, all of that, those risk factors should be the same and replicable across cohorts, if that makes sense.
Yes. I have one little question for clarity, Tara. If you go on your slide 16, I think if I have that right, 16 and 20, you show that young age of diagnosis is a predictor, or there's some significant, right? It's clearly, apparently, a whole lot less than other factors, though, right? Because wasn't it a factor of 1.2 as opposed to 4.5 or?
Yes, you're absolutely right. And I can here. Sorry, I'm scrolling back. I hope this isn't bothering you guys.
That's okay.
Yeah. So here, so essentially,
this
the
was
way
surprising. Yeah.
This
was
so
low, though.
Yeah. Well, it's low, but it's still. So basically, one of the things you have to think about when you think about odds ratios is the interval. So when we see age at diagnosis and you see that 1.2, what that tells us is that for every 1 year older at diagnosis, survivors were or 1 year younger, survivors were 20% more likely to be non-independent. So it's a 20% increased risk per year of diagnosis, if that makes sense. But you are correct.
Now
it is not nearly as strong. As I was saying earlier, we tend to see that craniospinal radiation is the major culprit, and it tends to override a lot of the other factors. But yeah, so that 1.2 is interpreted as a 20% increase per each year of diagnosis. Does that make sense?
Oh, yeah.
Okay.
Now it does. And I understand that that's significant because it falls within that 95% interval,
Yep,
as you said.
but you're right. You're right.
Okay.
Compared
Yeah.
to the magnitude of those other numbers, it is much smaller. You're absolutely right.
Well, I'm going to take a few seconds to see if some other questions get typed in. This is wonderful, and if people should know, perhaps you highlighted in the original slide, Tara, that you had a publication on this. So if really anyone wants to live and breathe the data, what journal was that published in again? I think you had a...
Yep, that was in the Journal of Clinical Psychology in September of this year. Yeah.
Yes.
So, and we are planning follow-up studies to see how this continues, to look at this longitudinally in survivors of CCSS. So, and we're expanding this beyond CNS tumor survivors as well. This is the group we started with because we know this is such a high-risk group, and we wanted to see what the concerns were in this group, and if they were present here, then to delve deeper with some of the other diagnoses as well.
Yeah, and the nature of the study is such that the cohort will always be, a few years behind in terms of treatment that may not have been available back then that are now, but because you're looking at 5 years or 10 years after they were treated.
Yeah, you're absolutely right. Yeah.
Right. Hopefully though, I think there shouldn't be a massive difference between, as you might see, between 79 and the year 2000.
Yeah, and even I think with some of the progress we're seeing, even though we're still a decade or so behind, the fact that we're seeing progress over the past several decades, hopefully only suggests that we're going to continue to see that progress.
Yeah. Well, thank you. I want to close out with first by again, thank you. This is a marvelous talk. I think it brings home the point that's near and dear to everyone's mission here as a TAC2 member, which is the story is not just survival rates, although that's important, and to some, that has a lot of attention. It's what life looks like as a survivor, how it's really experienced. So this drives the point home for CNS tumors. But clearly, I think we might even have the chance to look at this across other tumor types, very salient. So thank you very much.
Joanne, this is Vicki. I do have one place that I'd like to ask Tara to close with us. So Tara, as you know, the Coalition Against Childhood Cancer is a membership organization for childhood cancer foundations, over 100 of them, and also individual advocates. And what we often are really interested in is what investigators such as yourself, what kind of help or response or support you would hope to find from the community. And I know that a lot of our attendees, and at least the ones that I saw in the registration report, did represent childhood cancer foundations that specialize in brain tumor and fund research, and I know that you would like to probably draw the circle wider, not just on funding treatments and therapies, but also survivor therapies. Is there any other kind of enlightenment you can offer us based on your experience that our community, either as advocates or as funders or whatever, might be useful for this group?
Yeah, I mean, I think at least from my perspective, and I'm as a psychosocial and behavioral individual, I'm biased, but I think as you mentioned, survival has been such a fundamental aspect of this for decades, and it's sort of the crux of why we're here today, which is a great place to be. And I think over the past couple of decades, we've even done a great job of really characterizing these late outcomes, better understanding the consequences of therapy, and all of that information has helped to improve frontline therapies. But I think we're really at a point where we need interventions for these survivors. So I think we're beyond a point where it's saying, okay, we know you're going to have hearing loss. We need to start funding trials and thinking about things. What can we do to prevent hearing loss? Because we know you're going to get the platinum-based chemotherapy. We know that that's necessary for cure. What can we do on therapy to prevent long-term hearing loss? And then when you become a long-term survivor, what can we do to help you manage your life with the hearing loss? So I think from a survivorship perspective, we've really moved beyond sort of characterizing the outcomes to really trying to better understand what we can do to help these survivors thrive in everyday life, to become independent adults. And I think, for me at least, I think that's where funding is key. Is intervention trials are extremely time intensive, labor intensive. They're hard to do. They're hard to recruit participants to, but that's what we need to be able to disseminate and get information out into the hands of survivors. Hey, you have this late effect, but we've done a great study and we know what's going to help you manage that late effect. Does that sort of get at what you're looking for?
Tara, it does. Thank you. It's always good encouragement to ask folks to remember to do the hard things as well as the easy things. So yes, thank you.
Thank you. So thanks again, Tara, and to everyone for your interest and your participation. Speaking to those on the line, there'll be a survey going out. If you can take a moment, please, to give us feedback on this. We check those. We try to be responsive in our webinar series here to what you'd like to hear and what works well for you. So please fill that out and let us know. And again, I want to echo the announcement at the beginning, at the top of the hour, which is to be on the lookout for and respond to a CAC2 survey coming your way to help ensure that the next 5 years are as successful, if maybe we can even top ourselves. So thanks again for your attention. And onward, everyone, with our respective important missions, and enjoy the rest of this beautiful day. Thank you. Bye-bye.